Hello and welcome to this mini lecture about communication skills part 1. I'm Dr. Catherine Miles. So to make a beautiful cake takes time. It takes good knowledge, good ingredients and time to practice the skill of making a beautiful cake like this. And so we were saying these are the things we want to be teaching you also for consultations. The knowledge, the skills and the ingredients and the chance to be able to practice them. Because it's good to have knowledge, but you need to be able to show how to use these skills, not just know about them. So the Calgary Cambridge Guide is a framework that we use for the consultation to give us both the structure and the skills needed. It shows us how to start the consultation, gather information, do physical examination, do explanation and planning, and close the session, whilst building in structure and the relationship with the patient. So in our consultations, what are the communication skills that you need when talking with patients? Well, here's a bit of a long list of things that we will look at. Rapport, screening, active listening, open to closed question code, clarification, picking up cues, showing empathy, summarizing and signposting. And today we're going to look at the first ones of these, up to clarification. But first, it's important to think about what type of consultation do you want? Do you want to have a medical model consultation where you as the doctor are the centre? Or do you want to have a patient-centred model where the patient is involved and actually participates to determine their care and treatment? What are some of the differences between these two models? Well, in terms of listening or time taken talking, in the patient-centred model, the doctor listens more, whereas in the medical centre model, the doctor is talking more. In terms of roles, for patient-centred, the patient is active and participates, whereas the doctor-centred model, the medical model, the patient is more passive. In terms of how the doctor views the patient, for a patient-centred model, the patient is a partner with the doctor, whereas in the medical model, the patient is actually just receiving a recipient from the doctor. And again, in a patient-centred model, the doctor collaborates with the patient, works with the patient, rather than dominating the consultation. And in terms of the centering of these, patient-centred is about the quality life of the patient. It's trying to think about how is this affecting this patient in front of me, not just what is this disease. And we find that when we have patient-centred models, that actually patients adhere to the treatment plans. They follow through with the planned treatment, rather than in medical-centred models, patients may not feel that they've been heard, they may not feel they've been listened to or included, they may feel that they've just been told what to do and actually don't agree with it, so don't follow through with their treatment plan. So let's just have a look now at these two consultation rooms. Which do you think is more doctor-centred and which is more patient-centred? So as we can see, the one with the desk facing two chairs with lots of certificates on the walls shows a much more doctor-centred consultation style room. Whereas we can see in the other picture that the doctor is there with the patient, the way that the chairs are slightly facing towards each other allows for more collaboration, allows for more interaction. And he's actively explaining and showing and discussing with the patient their X-ray. So it's important to think about even the layout of the room. What does that communicate to my patient? As we looked at in the structure of the consultation lectures, the beginning of the lecture, of the consultation, is very important. We said they're the golden minutes to really build a good foundation to the consultation, with the patient. So of course we talked about introductions, and then it's important to develop rapport. Well, what does rapport mean? Well, that is a good relationship that you have with a patient when you are both communicating well and understanding each other well. And you can do this by showing interest in the patient, listening well, showing respect for them, taking care of their physical comfort. The other thing that's important at the beginning we talked about was about opening questions. And it's important to ask a good open question. So examples could be, how can I help you today? Tell me what you've come to see me about. What can I do for you? How are you doing? What has been happening for you? So over to you. Or even not saying anything at all and just indicating with your body language. Again, these different questions can have benefits and can have negatives as well. So you might want to think about what is your preferred opening question. And then, of course, we want to listen actively as the patient talks. So, what is active listening? Active listening is listening to somebody without interrupting them and paying close attention to what they are saying. It's taking the time to really understand what is being said. And to do this, we can use some certain skills, such as using eye contact. Of course, thinking culturally here what is appropriate between people of different genders, but to at least have face-to-face contact. You're not looking down at your notes or looking at a computer screen instead, but keeping some face-to-face contact. You want to not interrupt your patient. You can nod, yes, go on. Give them encouraging signs that you are listening to what they are saying. And you can demonstrate good active listening by not asking them a question they have already answered. So make sure if they have told you information, don't ask them again, unless you actually clarify and say, I just want to check, did it start 2 weeks ago or 1 week ago? And you can repeat back and echo to the patient. You can go, oh, so you said the pain is here, and then give them time to keep explaining more. The skill of summarizing is a very good skill to show the patient that you have been listening accurately to what they have been saying. And we'll talk more about that in the next lecture. So what about the presenting complaints? After beginning the consultation, we move on to find out those symptoms that the patient has. And some of the skills we can use at this time are screening and active listening that we've already talked about, and setting the agenda. So what is screening? Well, screening is checking if there are any other symptoms or problems. So to do that, you can ask, is there anything else? Or what else is there? If you shake your hand. Okay, so patients do not always tell you all their symptoms. And sometimes the first symptom they tell you is not the most clinically important. So you need to make sure you find out all the symptoms. It also helps you to keep to timing, because if you haven't found out all the symptoms at the start, then when you're closing the consultation, the patient might then ask about another symptom, and you have to start all over again. It takes more time. So it's better to find all the symptoms at the beginning. And then you can set the agenda or negotiate the agenda. This is where you're deciding with the patient which symptoms you will focus on today. You may not have time to explore everything. So you can ask the patient, you mentioned you've got hair loss and chest pain. For me, the chest pain is the most worrying symptom that you've got at the moment. Can we talk about that today? If there's time, we'll talk about the hair loss as well. Is that okay? Or you said you have a sore big toe and a cough and a lump on your arm. Which of these things do you feel is most important to talk about today? So that's setting the agenda. Then we move on to find out more about the symptoms. And we want to know the story and the timeline, the sequence. And to do that, we can use various skills, such as open to close questions, again, active listening, clarification, picking up cues, and summarizing. So questions. We sometimes call this an open to close question cone. So open questions need a full, long answer. It gives us lots of information. Closed questions have a short or yes/no answer. And they can be very helpful to find out some specific, what we call red flag or dangerous symptoms. A really helpful phrase, it's not strictly a question, to use to gather more information like an open question is to say, tell me more. So if the patient says, oh, I had this cough and a headache, tell me more about that. And they will, they'll tell you more without you needing to ask specific questions. So we start with open questions, and then we want to focus down onto a few specific details or symptoms that maybe have been missed, and we want to know that even if the patient hasn't told us. So we want to then ask closed questions. Then we can use something called clarification. Maybe the patient has said something that we don't fully understand. So clarification is when the patient uses words or maybe describes things in a vague way. The timing isn't clear. And we want to ask the patient to be more clear so that we fully understand them. So for example, you could say, tell me what you mean by dizziness. Or you could ask, when you say dizzy, do you mean that the room is spinning around? Or do you just feel lightheaded? So this helps you to really focus in on what the patient really means by what they're saying. So those are some of the skills that you can use whilst having a consultation with a patient. We will talk about some more skills you can use in part 2. So these are the resources, and just to say, we want you to have the knowledge and the skills and be practicing them so that you can become fully competent, not to make cakes, but fully competent doctors to treat your patients well. Thank you very much.